to Localizing the Infarct. So now we're going to actually talk about how to localize where an MI may have happened just based on an EKG. So as I mentioned before, this isn't a section where I expect you to be able to really recognize. We're going to do it for fun, for an assignment, and just see how much you take away from the different leads and to kind of see if you can get where the infarct may have happened. But really, I think the big takeaway for this class, and I really never had it, was being able to recognize an infarct. So that last section, looking at the T wave peaked, the inversion, the ST segment elevation, the Q wave development, those are really the big takeaways. So when I talk about like your final exam, for example, I'm not going to have you say whether it's inferior, anterior, or whatnot. Just being able to pick up that acute MI is going to be important. So with localizing the infarct, we know that there's two major systems of blood supplied to the myocardium. One supplies the right side of the heart, and the other supplies the left side. So we have the right coronary artery that runs between the right atrium and the right ventricle, and that swings around to the posterior surface of the heart. We have the left main artery, or the LAD, which runs between the two ventricles and supplies the anterior wall of the heart and most of the IVS, or intraventricular septum. We also have the circumflex artery that runs between the left atrium and the left ventricle, and this supplies the lateral wall of the LV. So that should just be a review for you, strictly a review. Why would we want to know where an infarct actually happened? Well, I think it's obviously important we know which area of the heart is going to be affected. And we can see that with echo too, and there's different ways we can see this. So usually before a person gets a cath, sometimes they don't have time. They get that EKG and they're going straight to the cath lab. Sometimes we actually we're able to do an echo before they go to the cath lab as well. So it just depends on that patient's status. So they essentially group the infarcts into different categories. So these categories can be the inferior, lateral, anterior, and posterior infarctions. So we're going to go through each of those. Majority of them obviously involve the LV because that's the power pump for the source of the heart. So if you go to the next slide, this slide is strictly for your reference. It's the EKG zones. I always like seeing things like this because it puts kind of it into perspective, but it's the different leads in relationship where they are in the heart and what coronary arteries they kind of follow as well. So I put that in there. That's reference for you to utilize. Along with the next slide is kind of a generalized, where would you see those changes, would be what type of heart, what part of the heart that's going through that infarction. Now, this does not always follow. I've gone through several of the slides, and it doesn't follow to a T, but it's kind of a nice little zone that I found that reference from the course, and I thought that would be helpful for you guys to see as well. So let's begin talking about inferior infarction. So we know that this is often caused by the occlusion of the right coronary artery. So we see this on EKG with the inferior leads. And those leads are leads 2, 3, and AVF. You'll see the segment, ST segment elevation. So, and the T wave inversion in AVL is a common change that you'll see. So that's like those reciprocal changes that we talked about, how in the other leads you see things. So you'll often see AVL have a T wave inversion with this inferior infarction as well. Let's see here. 50% of these patients actually lose their criteria for significant Q waves. So whatever happens with infarctions, the Q waves, 50% of the patients will keep those Q waves like we talked about with the standard MI. Others, that Q wave falls off for whatever reason. So that's just something to know. So the big takeaways are the right coronary artery is the one that does the supplying of blood. On EKG, you're going to mainly see it in leads 2, 3, and AVF. And then those reciprocal changes, you may see some T-wave inversion in lead AVL as well. And so there is an example on your slide. Next slide is lateral infarction. infarction. So lateral infarction, we know that it involves the left lateral wall of the heart, and it's often due to the occlusion of the left circumflex artery. You see your EKG changes in the left lateral leads, 1, AVL, V5, and V6. So reciprocal changes may be seen in the inferior leads as well. You obviously will see that ST elevation that you're seeing on this example in this chart. So pretty straightforward with the lateral changes or lateral infarction. So if you go on to the next slide here, which is anterior infarction. So the LAD, you guys may know of it as the widowmaker, right? So that's the big kahuna. So one example of the anterior infarction, you can also see that ST elevation can be called the tombstoning. So see how those look like a gravestone essentially? And I was first exposed to this in one of my stress echoes. So yes, the patient was on the treadmill and developed this rhythm. So that was my first exposure, because I never really had too much of an EKG class, but I had never in real life seen this. I've only studied it on my own. So it was pretty crazy to actually see this, and it literally looked just like you learn it. So this anterior infarction is the left anterior descending, LAD or widowmaker. Usually see it in leads 1, AVL, and most of the precordial leads as well. So that would be the V1 through V6, as we know. So the next slide is your posterior infarction. So this involves the posterior surface of the heart and is usually caused by the occlusion of the right coronary artery. Posterior infarctions, they rarely happen by themselves, but they usually accompany like an inferior infarction, lateral infarction. So it usually goes hand in hand. So that's why the EKGs can be a little bit harder to read. So looking at reciprocal changes can definitely be something to look at, because you're going to have different places of the leads affected for reciprocal changes. What you're doing is you're looking for ST segment depression and tall R waves in the anterior leads, which are V1 most notably. So keep an eye on that. So now we have that ST segment depression. So in a normal QRS complex at lead 1, or V1, excuse me, so in a normal QRS complex at lead V1, we know that it consists of a small R wave and a deep S wave. So now when we have a tall R wave with segment accompanied with ST segment depression, this is your sign of a posterior infarction. So these are a little harder to pull out, but that is your most common stance for a posterior infarction. Because you also see inferior infarction with it, you want to pay particular attention to those inferior changes on EKGs that we talked about. So the leads 2, 3, and AVF, getting that ST segment elevation as well. All right, so the next slide, right ventricular infarction. It's very rare, not going to be on your test. Don't worry about that. But they do occur, and they always occur majority of the time with inferior infarctions as well. So we're kind of seeing a trend here, right? So what you'll typically see are those inferior infarctions that I just mentioned. And then you'll also have T wave changes and ST segment elevation in the most rightward anterior lead, V1. So you'll see the inferior changes and those changes in lead V1. So that is something to pay attention to. I did not see these as much, but I know that it has happened. And so if you do get exposed to this, definitely pay attention to your EKG and learn from it. Next slide, non-ST segment myocardial infarction. So we call these NSTEMIs or non-STEMIs. So if you look in the slide that I pointed out, I just said what is normal for an ST segment, what's ST segment elevation with the STEMI, and then obviously with your NSTEMIs or your non-STEMIs. You don't get those deep Q waves. And then obviously not the elevation elevation as well. So instead, you'll notice on that third one down that you get the depression. So with NSTEMIs, you're just not going to have that gravestone effect like you would with a STEMI. Sometimes they still need treatment right away, and you need to be aggressive, and then in other times they are not as aggressive. Just a word to the wise, if you ever see anything of questioning or concern, make sure a doctor looks at it, because they are, at the end of the day, are the experts of these EKGs. So next slide, Takasubos. So hopefully you guys are all very familiar with this. I feel like a couple of people have already had case studies like this. It's insane. This to me is just the body just being so powerful and the mind being so powerful. But this Takasubos mimics an acute STEMI on the EKG. So, I mean, it has the T-wave inversions and ST segment elevation. So that's something that's pretty amazing. They call it the apical ballooning syndrome because you get the bulging ventricle. They also call it the broken heart syndrome because a lot of times you'll notice that this patient just went through a super traumatic thing. Oftentimes their significant other passed away. And it's almost like their heart was in shock or, broken heart syndrome. Like you said, it's just crazy. Eventually, the patient's EF and EKG return to normal, but it can take some time. But this is something I encounter quite often, really. I mean, especially in our today's society, it's just such a stressful place that really doesn't surprise me. But that just goes to show how important it is to really focus on stress handling. And obviously, you can't always fix that, but pretty amazing what a body can do. All right, next slide is angina without infarction. So we call this Prinzmetal's angina. So this is a medical condition where there is a temporary spasm of the CAD or coronary artery that causes pain and discomfort. So it literally looks on these type of attacks. The EKG demonstrates the T-wave inversion and T-wave depression quite often. So really, it's hard to tell by the EKG what's going on. Really, the only true tell sign that you can do in situations with this type of angina is measure the cardiac enzymes, that they will not be elevated if this is the case. But with a true heart attack, it would be. So that's your determining factor. So these are just a couple of things that mimic a heart attack, but actually aren't. So if you go to the next slide, the summary slide or table, it shows that type of angina, your Takasubos, NSTEMI, STEMI, and then all the stable angina and unstable angina. And it shows you the ST segment changes that happen, and then whether or not the cardiac enzymes will be normal. So that's a nice little slide for you to see if you're curious about it. Next is stress testing. So you guys have all seen stress testing. One thing to know when you're doing the stress testing, with a positive test for CAD, the EKG will reveal ST segment depression. T-wave changes are the two non-specific. So you really have to see that segment, the ST segment changing. If the ST segment depression is greater than 1 millimeter and persists for more than 0.08 seconds after the J point is suggested of CAD, is when you are considering it a positive, okay? So that is for stress testing. Contraindications, sorry, that was a mouthful, for a stress echo include acute systemic illness, severe AS, uncontrollable CHF, severe hypertension, and angina at rest. If you ever have anything you question, I would always go to the doctor and be like, hey, do we need to do this? If you have an abnormality on the EKG, a bundle branch block, they often won't even do stress tests for that. Then you have to go to the doctor and get that approved before you go through with the stress test. So let's see here. Here on the images, you look at image number 1, you see that down-sloping ST depression. That's on the first image all the way to the left. Number 2, or the middle one, you see an upsloping of the ST depression. And then on number 3, you see a horizontal depression. So So which ones would you consider abnormal for a stress test? Hopefully you said 1 and 3. So those are the two that are suggested of CAD. If you had the one in the second one, not so much. But those two on the ends are ones that we look for within a stress test or changes that may happen. So those are the changes you definitely need to get a hold of a doctor to peek at. All right, so the rest of the slides are just for your resource. So progression of changes is the next one, how that changes. The next one's acute MI. You can see kind of that gravestone effect in the leads, and then acute versus chronic MI. So the EKG changes as well, and then just another progression site. I feel like sometimes you need to go through this information on your own, just at your own pace, and then having those as a reference are really helpful. My goal for you, and I don't know if this is realistic or not, you're going to have to tell me, when you get out in the field, is this something that you can look back on, like your cheat sheets that you made, and something like these slides that would help you with EKG? Maybe it is, maybe it isn't. I think you get into labs where some people are more comfortable with EKGs than others, so obviously find the people that do feel comfortable with it. But you, as a cardiovascular sonographer, it's your duty to feel comfortable with what we've discussed thus far, as far as being able to recognize abnormal rhythms. You may not say, okay, I know this is a heavy block or whatnot, but something is just not right about it. And then I always used to learn, I still do when I'm there, from cardiologists. I'll take an EKG to them and be like, hey, what do you think of this one? And they, 9 times out of 10, they're pretty helpful when it comes to that. So I hope you found this section very interesting. As far as, like I said on the test, I won't make you tell me where actually the heart attack's coming from, because we're not getting that in depth, but you would need to recognize if there was an acute MI or a STEMI going on. I may have a bonus or something like that. And don't think it's a waste of time, your assignment for this week, because I just wanted you to play around with it and see, where you got. And I'll put out that answer key in just a bit as well. Thank you very much, and have a good rest of the week. Let me know if you guys need anything.